Hello, everyone, and good morning. Welcome to day 2 of the Voices in Renal Oncology seminar. Yesterday was absolutely fantastic. At one point in the day, I think we had over 6,000 individuals on the live platform. So we hope that you enjoyed the day yesterday. This is a kind of a new format. It is my honor to kick off the day. We're going to be talking about risk stratification and perioperative management and renal cell carcinoma. And it's my absolute pleasure to introduce to you Dr. Professor Gang Zhu, who's going to be talking about robotic surgery with AI-enhanced holographic imaging, bridging precision, efficiency, and functional preservation. Dr. Zhu, take it away.
Hello, could you hear me?
Yes, sir.
Oh, okay, great. Sorry, I don't know why, because we usually use the tools like Zoom. So this is something new to me. I'm not familiar with it well. So if you can play my, the PPT from your stage, and so I can start my talk. Yeah. Oh,
Our OncoDaily team is going to be helping us.
Let me try. I'm not.
You can also share screen. There's a share screen button.
Could you see me now?
We can see you. We can't see the slides.
Okay. I don't know why. Something strange happened. Yeah. I don't know. Maybe if you can. It's something weird. Yeah. But anyway, being can someone share the screen for me and. Where is one window? Screen. Let me try now. I'm not sure if you can see. Could you see me now? Hello. Could you see me now? Hello. Hello, Rana. Could you see me? Okay, now I try to share. Could you see me now? Hello, Rina. Could you see my slides? Can anyone hear me? I really don't know. The entire screen. Share. Each episode. Can anyone play my 这东西咱们就下载。Augmentation，这个有点怪了，怪怪的。 好了，他把那个Can I start? Hello. Okay. Thank you much for the kind invitation. Sorry for the I'm familiar with this tool but on behalf as a representative of China Anti-Cancer Association, I'm here to present the robotic surgery with AI-enhanced holographic imaging. Can I next slide, please? Hello. So, do you see the slides? Because the host muted my microphone, so I'm not sure it can be correct. Can anyone show me next slide, please? Let me try if I can. Okay, I have no conflicts of interest to share. Next one, please. Okay, actually, as a surgeon of Neuro Oncology, we are facing a lot of challenges, particularly in renal cell carcinoma. We are thinking of how to personalize the surgery, and also in the area of AI, how to use AI to to have a better decision making, and also how to achieve better precision surgery and improve patient safety. And in terms of oncological control and also the functional preservation, how to balance this. These all are the challenges to us. Next one, please. Yeah, we are in the area of evolution in radiology. So that is mean we are evolving from 2D to 3Ds. Next one, please. Yeah, that is the solution can be the holographic imaging with the robotic surgery. So what is holographic imaging? Holographic imaging is the AI-based virtual reconstruction technique converts the 3D the 2D CT and MRI data from 2D to 3Ds. Next one, please. So actually, the AI can help us convert the CT image from 2D to 3Ds. And here we're presenting the comparison of CTA to holographic imaging. As you can see, the holographic imaging, they can show in the better of artery vein, renal collecting system, and also can presenting very fine anatomy, and those they can freely combine all the structural, especially relationship of the structures. And also you can use this too to design the operation. Next one, please. And nowadays, with the AI technique, we can create the holographic imaging within 3 minutes. So it's really becoming very, visible, very easily to accept this technique. Next one, please. Yeah, so far this holographic imaging in kidney surgery has been used in the following areas. Next one, please. It is in medical education and the training. As you can see, previously we learned the anatomy from this illustration. You know, I think the medical students, even the junior surgeons, they want to learn the anatomy with more advanced AI technique. And here, the holographic image is very good too. Next one, please. And here's a real case. And you can see, actually, I have a lot of movies inside. It's not moving, but it's okay. And you can see, compare with the CT and holographic imaging, not only becoming more colorful, but also you can see all the details of the structure and also the special anatomy, and then you can plan the surgery better. Next one, please. And also you can use for the patient education consultation. That means you show this holographic imaging to the patient. Patient will understand what is the problem and what are the surgeons going to do and what are the potential risk of this surgery. They can easily understand this surgery and they cooperate well. But next one, please. And this is just showing how I do the surgical planning for the hemi-nephrectomy for left kidney tumor cases. I can draw on the holographic imaging, and I will meet what I saw on the holographic image in robotic surgery. Next one, please. And now we're moving from intraoperative navigation. That means, previously when we, want to check the anatomy, we have to off the operation table to check on the light box. But now you just sitting on the robotic console, and you can see the images, holographic images in the abyss endoscopic image. Yeah, next one, please. And this is showing the fusion of holographic imaging with intraoperative surgical view. And by this way, you will be able to see what are the structures underneath the surface. And they can be tumor, can be important vasculars, and maybe a collecting system as well. Next one, please. And this is I studied this technique from 2019, and you can see obviously this is a very difficult case. We do it on the robotic surgery, and it's being very precisely achieved, the removal of the tumor. Next one, please. This is just showing, we even without intracorporeal ultrasound probe, we can use the holographic imaging to locate the tumor, the endophatic tumor, so we can achieve a precise partial nephrectomy. Next one, please. And this is the renal hilum tumor. It's in very most challenging cases, and we do the navigation during the procedure, and it's facilitated the partial nephrectomy, and we can achieve very good results. Next one, please. And it's also navigation evolving. It's keep improving. Previously, this image need to be controlled by the assistant. Now the console surgeon, me myself, can control this the movement of the image, so we can have a better navigation. Next one, please. And I'm always encouraging my colleague to do the functional sparring during the uro-oncology. So I always, give a lot of lectures, talks nationally, internationally, particular for the renal kidney cancer. I always say for the T1 cancer, whatever you do, open surgery, laparoscopic surgery, or robotic surgery, try to preserve the kidney as much as possible because they are oncologically the same. Next one, please. And this is, you can see obviously this is a complete endophatic tumor, and with the help of the holographic imaging, and we've been having a thorough discussion with the patient, and we achieved the partial nephrectomy for this patient. And yes, you can see obviously this patient still in very good oncological control. Next one, please. Yes, this is something I regret. That was in 2015. I did a cytoreductive nephrectomy for case with a spinal bone metastasis. But then I find out why we couldn't do the cytoreductive partial nephrectomy rather than nephrectomy. Next one, please. Then we search the literature, we search the guidelines. In the European patient information, there's option for the cytoreactive partial nephrectomy. Next one. Yes, was in 2017. There was a UCLA study showing if the tumor smaller than 4 centimeters, the patient may benefit from the partial, cytoreductive partial nephrectomy for the MRCC cases. Next one, please. Then we meet this case. This was 2019, and this gentleman is very fit. ECOG is 0, and he has a 6.5 centimeter right kidney tumor, and with a bilateral lung metastasis. Next one, please. And you can see with the help of holographic imaging and robotic surgery, we did a cytoreductive partial nephrectomy for this case. This was a WHOG4 sarcomatoid features. And yes, it's a high risk of recurrence patient. Next one, please. And after surgery, we provided the patient with pepro plus asetinib. And after 9 cycles of treatment, as you can see, the lung metastasis shrink and nearly disappeared. I have just recently contact with the patient that is still, very active in social activity and still have sort of exercise in very good status. Next one, please. Next slide, please. Yes, regarding the cytoreductive nephrectomy, we know a patient, the MRCC patient may benefit from this surgery. Next one. But we do know there was some debates on the patient. Should we process for the cytoreductive nephrectomy or not? This is a Kamina study. Find out for the post-state patient. Maybe it's better treat the patient with targeted therapy. Next one, please. Yeah, this is a result of the study. As you can see, if this patient in poor status as poor risk large primary tumor, they may not suggest for the partial reductive nephrectomy. Next one, please. Next one, please. Yes, even this being supported by European urology guidelines. Next one, please. However, in the real world practice, you meet a patient like this. She's a young patient with a right huge, big 9.8 centimeter tumor and compressed IVC and has a lot of metastasis. Has lung and adrenal gland, liver, retroperitoneal, mesenteric, and soil muscles, and a lot of metastasis. What would you do? The IMDC is a poor risk. Should we perform the cytoreductive nephrectomy for this lady? Next one, please. On the holographic imaging, I studied it very carefully, and then find out this is even she's very in poor risk, but I find that technically still feasible to operate her. So I discussed with this lady and we decided to do the surgery for her. Even this was high risk. Next one, please. So this is a position and robotic docking for this lady. We did it in this April. Next one, please. So this kind of surgery, we must be very, very cautious, do very careful dissection to protect the duodenum. Otherwise, this will be a catastrophic complication for this lady. But we've been very successful on this case. Next one, please. And then we did the nephrectomy for this case, achieved the right side nephrectomy and also cytoreductive negative. Next one, please. And we achieved the partial adrenalectomy, and we preserve her adrenal function. Next one, please. This is a metastasis on the right thoracic muscle, and we did a mastectomy as well. Next one, please. Just a few more slides. And our orthopedic surgeons did the femoral head replacement to do the cytoreductive procedure for her. Next one, please. And we put on her the pembro and the axitinib, and you can see it's only 3 months after there was no recurrence, and the lung metastasis shrinked. She's in very good status. I just saw her a few days ago. Next one, please. So, with a more advanced machine device, even for the small tumors, we even can do the single port robotic surgery to remove the kidney's tumors. Next one, please. Yeah, just in telesurgery has been developed very well in China and the worldwide, and it's being not only being performed by the Chinese surgeon, but also worldwide from Europe to China, from China to Africa. So it's being feasible now, technically feasible now. So it will helping us decentralize the medicine. So everywhere can can share this advanced technique. Next one, please. So for the future directions, I think we can combine the holographic imaging with the PET scan, and then to define the anatomy, functional, and metabolism of organ and the tumor. So this will enable us to achieve personalized, precise tumor excision, and also the full cycle recovery, not only the before the surgery, but also the post-surgery for the recurrence prediction, and also customized rehabilitation. For sure, the telesurgery is empowered by 5G and holographic imaging will achieve better results. Next one. Next one, please. Yes, actually, we have already achieved the fusion of the MRI with plasma PET scan, This is on prostate. Surely, I think we can do this on kidney tumor as well. Next one, please. And under the leadership of Chinese Anti-Cancer Association, we have just finished the guidelines on holographic imaging. Next one, please. And in summary, and so I showed you the holographic imaging can be used in patient consultation, education and training, and the surgical planning and the surgical navigation. For the future, I think multimodal integration of holographic imaging with PET scan will advance the kidney surgery from precision resection to personalized treatment and functional preservation better. Next one, please. I want to thank for the organizers for the invitation again. Sorry for the technical problem, and I would wish this meeting be a great success.
Thank you so much, Dr. Zhu, and sorry also for technical problems. And now we can move for our next speaker, Brett McGregor, Director of Clinical Research for the Lang Center of Geriatric Oncology, Medical Oncologist at the Dana-Farber Cancer Institute, Assistant Professor of Medicine at the Harvard Medical School. Thank you for joining us. The floor is yours, so we will share your screen.
So should I share my own PowerPoint slides?
No, we can. We will
You
share
have them.
your
I
screen.
sent them to you already. Okay, there we go. Perfect. Okay.
Right.
So again, thank you so much, and I am excited to be here. As we think about the advances we've made in the perioperative setting for renal cell carcinoma, and for purposes of this, I'm really going to be talking about clear cell RCC as we look for obviously risk stratification and how can we actually improve outcomes overall. So next slide, please. And here's my disclosures. Next slide. So at the end of the day, one of the key questions you ask is why do prognostic models matter? And I think for the longest time, prognostic models were used purely just to educate the patients about how they were going to do overall, but we didn't have anything we could really offer that patient, right? So we know that in localized disease, surgical management is really the standard of care. And so patients have surgery and they come into the clinic and like, well, how am I going to do? And we have these different models help us out. And they've been a mainstay. And I think now, I think it's becoming more challenging as we do have these prognostic models. And the question really is, how can we use these in the advent of systemic therapies that have made an improvement in the adjuvant setting? And so as we look at some of the commonly used prognostic models that have been established, we're going to start with that historical reference. A lot of these are all focused on clinical features as well as pathologic features at the time of surgery. Starting with the UISS and then the Leibovitch, the S sign. And the one I tend to use the most in the clinic is the ASSURE, just because it is very simple to use, gives some nice graphics for the patient in the clinic using web-based nomogram. Next slide. So as I alluded to, of these features where you're looking to use clinical factors. And so the UISS, it's really quite simple. So this is, using the 1997 TNM staging. So it looked at staging system as well as grade and then performance status, right? So pretty simple. You can say if a patient has a really good performance status, a low stage, low grade, they're going to do great. And that was the group 1. And then the intermediate group was the rest of those patients, generally with like low stage, low grade, intermediate stage, low stage, any grade, intermediate stage, lower grade. Again, good performance statuses. And then you had the high risk, which is a very diverse group of patients that included the higher stages as well as the higher grades. Next slide. And we could see that using these factors, we could sort of characterize how patients do overall. And we can see that those patients with like a low grade, low stage, they did exceptionally well with, cancer-specific survival, like close to 100% at the 5-year point. But those patients were in the highest risk, you can see that, nearly all those patients were dying of disease by 24 months. So this gave us some idea on how patients do. And I would comment that while this was published, over 20 years ago, I would say that as we look at some of the newer data, we're doing much, much better with our perioperative therapy. Next slide. So the UISS only used these 3 different factors. Obviously, as you start adding in more factors, we can make a bigger difference. And so this is a nomogram where you basically assign points, and it looks beyond the TNM staging, looking at just straight up size, grade, and the presence of necrosis. And again, we're able to get a much better idea and can prognosticate with a little bit better accuracy, how patients are going to do based on all these different factors. And we can see variability from a score of 0 to 2, where, your 7-year cancer survival is like 90%, whereas if you're over 10, it's down to less than 20%. So again, helps us in the clinic with a patient. Next slide. Similarly, with a Leibovitz score, has a lot more factors that are involved, developed with the Mayo Clinic. And again, looking beyond the TNM, also including the ECOG performance status, constitutional symptoms, what surgery did they have, what were the surgical margins, was there tumor thrombus, what extent of tumor thrombus. And actually, there's different scores if you're looking at overall survival versus cancer-specific. Cancer survival versus progression-free survival, and really did give us some insight how the patients are going to do. Next slide. As we look based on the scoring system, you can have quite, again, a lot of variety. So there, for all of these, I've just gone through, you can go to like MD Calc or something else, and you can actually you can plug all these in and have these numbers to talk with the patient. Along the same lines, the Assure nomogram, next slide, was based on the Assure trial. Again, it's a relatively simple nomogram. It's web-based. You put in the age of the patient, the tumor size, the histology, the grade, sarcoma features, and you get some nice curves looking at cancer-specific relapse as well as overall survival. And you really get an idea of those patients are going to have early progressors. I will tell you, I find this incredibly helpful in the clinic as I start counseling patients and as I try to get into the idea of how can I quantify the absolute benefit from some of the adjuvant therapies. Next slide. So as I point out too, the question really is, how do we use these models? How do we use these prognostic tools in the clinic in the era of adjuvant therapy for renal cell carcinoma? So you look at renal cell carcinoma, obviously systemic cytotoxic chemotherapy has never played a role. We had the onset of TKIs in the metastatic setting, improving progression-free survival. And so subsequently, multiple trials were done looking at the role of TKIs, including the Assure trial against sunitinib, sorafenib, Source, just sorafenib, STRAC with sunitinib, Protect, pazopanib, Atlas, axitinib, and then Everest, everolimus. And I think that there was some mixed results. At the end of the day, only one of these trials, STRAC, showed improvement in disease-free survival. Next slide. And this trial was really focused on those patients with the highest risk disease. So, the T3 or higher. And we saw this very clear benefit in disease-free survival, but this did not translate into improvement in overall survival. And it was relatively poorly tolerated, with 30% having to discontinue for toxicity. And interestingly enough, the investigator-assessed DFS was negative. And so I would say, as we start thinking about the role of immunotherapy, we'll say, well, there's one pilot trial, it's a negative. We have same thing, immunotherapy, it's the same story. I would argue it's quite different. STRAC, this was a trial where we had the same TKI for the same duration in both trials with differing results. And so I do think that we're in a new era. Ultimately, while sunitinib was approved by the FDA, it really wasn't readily adopted in the clinic given the toxicity and the lack of OS. Next slide. As we see, when we look at all the trials that were done, looking at the role of adjuvant immunotherapy, despite the approval of sunitinib and having that data, all of these trials used either placebo or observation as a control arm. And again, we've done multiple trials looking at the role of immunotherapy. I'm interested in time only going to be focusing on the positive trial, but Emotion 0 looked at a year of atezolizumab versus placebo. That was a negative trial, no pregnancy survival. Checkmate 914 looked at 6 months of nivolumab with ipilimumab or 6 months of nivolumab, again, a negative trial. And then Prosper RCC looked at the role of perioperative nivolumab with a dose before and doses on the backside. Again, a negative trial. And I'll get into some of the thoughts about why they may be different. But Keynote 564 was a positive trial with both improvement in disease-free survival and overall survival. Next slide. And so I think I want to highlight, and I apologize that the animations didn't go through here, but this was a large randomized trial where they took patients who had localized resected clear cell renal cell carcinoma and were randomized to pembrolizumab for 1 year or placebo. And I did not highlight the eligibility criteria because ultimately, while we have all these great prognostic models, as you determine today who to consider adjuvant therapy in the clinic, we are really going to be using the eligibility criteria from this trial. And so this was histologic confirmed clear cell renal cell carcinoma, T2 grade 4, or sarcoma features. I note they put that in eligibility criteria. All sarcoma is grade 4 by definition, but I think by adding this in, they really brought this to the investigator's mind. Hey, they have a T2 sarcoma. I should think about this trial. T3 any grade, and then they allowed T4 any grade, no positive, and they allowed an M1 NED. So these are patients who had a nephrectomy and then either had a synchronous met that was resected or had a metastasis resected within 1 year. So as we look at the Emotion 0, the atezolizumab trial, they actually required M1 NED over a year. So this was sort of focusing on those highest risk groups. Given they had a resection, patients with brain mets or bone mets were excluded. Patients also had a good performance status. Next slide. And so I do want to point out that even though this is the criteria that I utilize, this still incorporates an incredibly high risk of patients. And this is some data that was previously presented looking at your database. So if you have a T3 grade 1 to 2, your 5-year PFS is 63%. Whereas if you're in that high risk group, your 5-year RFS is 15%. So even though this is these are the highest risk groups, we can see they're quite different overall. And just that grade, even within T3, that grade going from grade 2 to grade 3 has market impacts on their RFS. And I see that in the clinic all the time. They do their Schur nomogram and I plug in the numbers and I educate the patient on that points of grade because I just plug in this is a grade 2 versus grade 4, and you can see that market difference. Next slide. So who was included in this trial? Again, given that this is a wide range of clinic, was this really all the super high risk patients? And I would say a majority of the patients were what we're going to see in the clinic. So, over 85% of these patients were those T2 grade 4 or the T3 N0, that intermediate high risk group. Less than 6% were this M1 NED group. As we start thinking about impacts of subsequent line therapies, how many patients had access along those lines? So over 50% of patients were enrolled in North America or the EU. We would think that there should be good access to second line therapy, and about 10% sarcomatoid features, which we know is a prognostic but also predictive tool as we start thinking about the role of immunotherapy. Next slide. So we've now seen extended follow-up. There is a clear improvement in DFS, but hazard ratio right around 0.7. I think there's an early separation of the curves. And what is important is that as we continue to follow up, that separation is maintained. So it's not something that as therapy was stopped at 1 year, that by 2 years, there's suddenly the curves collapse. There's a clear early benefit that's maintained with extended follow-up, and we can see this, hazard ratio of 0.7 with an absolute benefit right around 10% or so. Next slide. And this has translated into an improvement in overall survival that is statistically significant, with around this 5 to 6% absolute benefit at the 5 to 6 year point. And if we look at all the different subgroup analysis, there's not one patient group who does not benefit. Next slide. This is associated with toxicity, and these toxicities are especially important when we think about adjuvant therapy, where patients may not need therapy. I think if you look at that, 50 to 60% may never relapse, and so we may be giving them treatment unnecessarily. And so toxicities matter. 10% had high-grade toxicity needing steroids, which I think is helpful. Next slide. I think what is noteworthy is focusing on the rare but life-threatening things that can change the options, right? In the stage 4 disease, if a patient has these toxicities, we sort of are willing to accept it. But in earlier stage disease, where we may not need anything, like if we cause a patient have AI or type 1 diabetes, again, incredibly rare, less than 1%, that can have impact. So I think it's important to counsel patients as you have that shared decision with the patient. Next slide. So at the end of the day, I think the real question is as we think about this in the clinic, we have one positive trial, one negative trial. What's the case? Like, right? How do we sort of take this data? And I think one of the key things we look at this is that patients were not the same. So if we look at KEYNOTE-564 versus some of the other trials, KEYNOTE-564 really had only clear cell disease. They did have that M1 NED histology. They, had a decent amount of sarcomatoid histology in the grade. And so clearly the patients aren't exactly the same. So that could certainly account for some of the differences. Next slide. And we can see that if we just look at this by looking at how did the placebo arm control in these. If we look at these different trials, there is clearly some differences. While the observation arm in Checkmate 914 did much better with that 24-month DFS 17%, 67% in KEYNOTE-564. And so when we're talking about a 10% absolute benefit, that this can make a difference overall. So again, the patient's role were not exactly the same. Next slide. And so the real question is then, if clinical features may not be the best options, what do we have beyond that? And I would say ctDNA, while there's been a huge push in urothelial and other cancers, it's really not ready for prime time in renal cell carcinoma. I think if a patient has detectable ctDNA using currently available assays, this is associated with an exceptional positive value. Nearly all patients relapse, but a negative value really doesn't help us prognosticate any further. So I think we're gonna have to look at novel approaches at looking ctDNA, like ChIP-seq, or start going to whole exome. And so I think this is developing overall, and a few trials examining this will be critical. But for right now in the clinic, I'm not using ctDNA. Next slide. I think something that's got a lot of interest from work from Dr. Xu at our group is the role of KIM-1. So KIM-1, or kidney injury molecule 1, this is a CLIA certified test, uses a very minimum amount of blood, and there's been exceptional work that's showing that post-nephrectomy KIM-1 is a prognostic marker. Patients with elevated KIM-1 have a worse outcome. Those have a not. And that what that cutoff is depends on what assay you're using. So we've seen that with Assure. We looked at the Checkmate 914, and we've seen that in Motion 010. Next slide. And it appears that it is a predictive marker in Motion 010 with those patients who are high versus low. Those patients who are high there's a switch in the curve. They did better with the atezolizumab. Those who are low, no benefit. We saw a similar hint of benefit in Checkmate 914 with adjuvant Nivo or Nivo-Ipi. Next slide. And so I think KIM-1 certainly intriguing. Future trials will be looking to improve upon that. But then I think that the next question is like, why can we do better? So you could say, well, we need do we need prognostic models to, not overtreat? But the same question, there are 20% of patients that relapse despite this therapy. So how can we do better? And so trials have been done. V940 uses a personalized mRNA vaccine to try to enhance the immune response. Overall, really exciting results in melanoma. This was recently completed accrual, and we look forward to the results using a personalized mRNA vaccine with Pembro versus Pembro with a placebo. Of note, I think what's interesting is this trial does not include T3 grade 1 or 2, and it allowed papillary RCC. Next slide. So again, I think the other question as we think about this is why could there be positive results with one, negative with the other? I think at the end of the day, the drugs are not the same. If you look at the activity in the metastatic setting for these different drugs, pembrolizumab versus nivo-ipi versus the PD-1, they are quite different. The duration was not the same. Pembro used a year. Nivo-ipi only used 6 months. Nivo-ipi, unfortunately, while there's 6 months, a lot of patients had discontinued earlier for toxicity, so further changing duration. So as we look to the future, I think we want to try to develop trials where we're prioritizing that year of pembrolizumab, but hopefully can add in a way which doesn't cause toxicity and allow optimal duration of therapy. Next slide. And so that has been sort of looked at with using a HIF-2 inhibitor. So this is LightSpark-022, looking at a year Pembro with or without belzutifan. So this trial has completed accrual, and we look forward to the results in the future. Really very similar criteria KEYNOTE-564, extending the M1 NED group out slightly from the 12 months, which I think will be interesting data. Next slide. And along the same line, again, looking to improve outcomes for those patients who may relapse with Pembro alone. This is Strike, now open through Alliance A032201. Again, exact same criteria as KEYNOTE-564, with one caveat is that we're allowing M1AD within a year, and as opposed to having surgical management, we are allowing ablation or SBRT, although we're still excluding bone mets or brain mets. And so again, focusing on that toxicity management, I think sunitinib was not adapted because of toxicity. Tivozanib is a well-tolerated TKI, so we're looking to get patients Pembro for a year with or without 6 months of tivozanib, a very well-tolerated TKI. See if a short course of TKI can improve outcomes. Next slide. And beyond the clinical question, I think we are really looking to learn from the patients and putting their trust in us. And can we answer some of those questions? Who needs adjuvant therapy? Who responds to adjuvant therapy? And so we're doing optional radiomics, and we're collecting blood to look at markers of minimal residual disease, Chem1, hopefully novel ctDNA tools, as well as looking at cytokines and tissue to see which tumor responds to therapy, which patients respond to therapy. And so we're going to learn more from this trial than this simple question of does tivozanib improve outcomes. So this is now open through the NCI, and I would encourage everyone to open this at their sites if they're able to. Next slide. So as we conclude, I think that I do want to emphasize adjuvant therapy pembrolizumab provides OS in the adjuvant setting. We have prognostic models, but ultimately, right now, we're really looking at the eligibility criteria for KEYNOTE-564, where you have to look at T2 grade 4, T3, no positive M1AD within a year. And I think that novel biomarkers and approaches are needed to prognosticate beyond clinical factors. I think Chem1 is the one that's most exciting, but there's more to come. And for today, we can use prognostic models to sort of better define and quantify the absolute benefit associated with therapy. So with that, I'd like to thank you for your attention, and we'll move on to the next talk.